Welcome, everyone. You are joining the Grand Rounds program at Silver Hill Hospital. Thanks for being with us, and we'll get started in just a moment as people settle into their Zoom boxes. All right. Welcome, everybody. I am Dr. Jeff Katzman. I'm the Director of Education here at Silver Hill Hospital in New Canaan, Connecticut. We are absolutely delighted to have you join us and are privileged to welcome Dr. Sanjaya Saxena, who will be presenting on the topic Obsessive-Compulsive Disorder and Hoarding Disorder. And I will have the pleasure of introducing him in a moment. Just first, a little housekeeping. Our next Grand Rounds will take place on November 29th, when we will welcome Dr. Patricia Harrison-Monroe to present to us on Beyond Implicit Bias, Providing Care Within an Inequitable System. And as a side note, for our social work attendees, Dr. Harrison-Monroe's program has been approved for cultural competence for licensure renewal for social workers. For today's lecture, your questions remain an important part of our Grand Rounds. I will moderate a Q&A discussion with Dr. Saxena at the end of his lecture today. And it's a great opportunity to put forward questions and comments to Dr. Saxena, which you can submit absolutely anytime during the lecture using the Q&A box. If you would like to receive CME or CEU credits, please complete the evaluation survey that will automatically show up in your browser when we end the webinar. And we'll also email you a copy of the survey following the presentation. And finally, our disclosures. No planners of this activity have indicated a relevant financial relationship with an ACCME-defined ineligible company whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. And now it is my great pleasure and honor to introduce our guest speaker today, who is a very old friend of mine, Dr. Sanjaya Saxena. And I've known Dr. Saxena for a long time, since we were psychiatry residents together at UCLA a minute ago. And I've known him always to be an extremely bright and caring clinician. And everyone we trained with always thought the world of Dr. Saxena. So much that in various positions I've had along the way, I've always tried to recruit him to where I've been working. And so I am happy, Sanjay, I've been able to recruit you to be a Grand Round speaker today. So let me tell everybody a little bit about you. Dr. Saxena is an internationally known expert on obsessive-compulsive disorder, hoarding disorder, and related disorders. He has been the adult psychiatrist at Rogers Behavioral Health in San Diego, providing intensive treatment for obsessive-compulsive disorders, anxiety disorders, and depression in their partial hospital and intensive outpatient programs. He's also a clinical professor at UC San Diego in their Department of Psychiatry. He's a distinguished fellow at the American Psychiatric Association and a fellow of the American College of Neuropsychopharmacology. Dr. Saxena received his Bachelor of Arts from Swarthmore College in Pennsylvania and earned his medical degree from the University of Minnesota Medical School. He completed residency, as I said, at the UCLA Neuropsychiatric Institute and did a neuroimaging research fellowship with the UCLA Department of Molecular and Medical Pharmacology. He served as the director of the UCLA OCD Research Program and associate director of the UCLA Anxiety Disorder Programs for 10 years prior to 2006, at which point he was the director for about 15 years of the UCSD Obsessive-Compulsive Disorders Program. He's also served as the director of the Veteran Affairs San Diego Anxiety Disorders Clinic and the director of the UCSD Outpatient Psychiatric Services. Dr. Saxena serves on the scientific advisory board for the International OCD Foundation and was an advisor to the DSM-5 work group on obsessive-compulsive and related disorders. He and his colleagues developed the DSM-5 diagnostic criteria for hoarding disorder, and he's been quite involved in teaching psychiatry residents and psychology trainees, earning outstanding faculty awards on multiple occasions. His research is focused on the neurobiology and treatment of OCD and hoarding disorder and related disorders. He's authored and co-authored over 80 scientific articles and book chapters, and has presented his work at major national and international scientific meetings. He's received his awards and grants from the American Psychiatric Association and American Neuropsychiatric Association, among other foundations. His work has garnered attention from local and national media, and he has a list of his appearances, actually, which is far too long for me to say here, but has been presented on every news station that we know. And I also had the joy of being in a movie theater at one point and watching As Good as It Gets and watching the credit, and there was his name as the medical consultant. So, Dr. Saxena, I'm so happy to see you, and thank you so much for being here and teaching us all today. I'm going to turn the video to you, and I'll disappear here, but I'm right here, and then I'll come back and we'll have a Q&A.
All right. Well, thanks so much, Dr. Katzman. You know, as Jeff said, we've known each other since residency a long time ago, but I've followed his career from afar, rising to various leadership positions in New Mexico and now here at Silver Hill. So it's so great to catch up with him after a very long time, and I very much appreciate the offer to come and present today. So let's go forward here. Let's see. All right, so I think he discussed the disclosures. I don't have any relevant ones to present. These are the educational objectives for the continuing education portion of it. And as it describes, since we're covering two major significant disorders in a very short period of time, I'm going to kind of provide a clinical overview. And I won't go into a tremendous amount of detail on all the different aspects, but the material will be there on the slides. And I think Jane mentioned that you'll be able to obtain copies of the slides on PDF form. So we're going to talk first about obsessive-compulsive disorder and then about hoarding disorder. And there'll be some time to go into kind of comparisons and contrasts between the two disorders and the differences in their presentation, in their cognitive behavioral therapy, and their pharmacotherapy. All right, so first of all, why should you know about OCD? You know, as clinicians, I know that most of the audience are mental health clinicians, psychiatrists, psychologists, social workers, therapists, etc. Why is it important to know about OCD? Number one, because it's pretty common, right? So lifetime prevalence about 2.3%. So an estimated 8 million Americans have had, do have, or will have fully diagnosable OCD within their lifetimes. In any one year, the 12-month prevalence is about 1.3%. So again, about 4 million Americans in any year. The lifetime prevalence of having any significant OCD symptoms at all, any obsessions or compulsions, but not necessarily meeting criteria for the diagnosis, is about 28%. So what this tells you is just like with virtually all of our other psychiatric disorders, mood disorders, anxiety disorders, psychotic disorders, these disorders exist on a continuum with normal experiences. And we put the cut point in terms of making diagnoses really based on the severity of the symptoms and their impact on somebody's functioning. And this is true all across our field. So what is the impact of OCD? In addition to being common, it's quite impairing. It's associated with low quality of life and significant functional impairment. Almost 2/3 of people diagnosed with OCD report severe role impairment in at least one major domain of functioning. It could be their work, their education, their social life, their home life, their physical health. Up to half become unable to work or continue their education at some point in their illness. It also is an independent predictor of suicidality, even aside for, even if controlling for comorbid mood disorders. So there's a 36% lifetime prevalence of any degree of suicidal ideation. In large clinical surveys, 11 to 15% of patients presenting with OCD had a prior suicide attempt. 10 to 16% present with current SI at the time of presentation. And unfortunately, even though it's common, even though it's disabling and has quite a major morbidity, very few people in our field even really know how to diagnose or treat it properly. And that's been a source of frustration for so many of the patients I've worked with over many decades, and it continues to be a problem in our field, because I think part of what happens is many disorders like this don't get covered enough in training programs. And it really varies depending on where somebody has their residency program or their master's level program or psychology program. And a lot of training programs, especially at the master's level, don't always cover OCD, and they don't cover behavioral therapy. So out of the many, many therapists out in the country, only, unfortunately, a small percentage really know how to diagnose it or treat it properly. So I'm always pleased to provide more education to the public and more education to clinicians, because it's really important that people know how to treat these disorders, and that flows from understanding the disorders at a deeper level and understanding how to diagnose them and recognize them. And as you can imagine, there's a great problem then with untreated illness. An average of 7 to 8 years of having untreated, fully diagnosable disorder before people reach their first treatment. And that's true in studies in the United States as well as in Europe. And that produces a cost. The treatment cost for OCD, even despite the fact that most people with OCD don't actually get treatment, even those who do, the cost is over $10 billion a year in the United States alone. And OCD, as I mentioned, is quite disabling. So this is an older slide looking at a World Health Organization study done primarily in the 80s and early 90s on the leading causes of disability. Nowadays, the current major causes of disability are still similar in the developed world. In the developing countries, disorders like AIDS and other infectious diseases are close to the top of the list. But in most Western countries, it's still somewhat similar to what you see here, where the most disabling disorder by a long shot is unipolar major depression. And then 5 out of the top 10 rather, including OCD coming in at number 10, of the major disorders causing disability in the world. And these figures that you see here, this total in millions, is a composite figure that incorporates the number of people who have the disorder, how long they have it, and how much disability is caused. And one of the reasons, of course, as we know in our field, that our disorders tend to produce long-term disabilities is because they strike people very early in life. And they're not fatal initially, even though, yes, there is certainly a risk of suicide. But most people live with these disorders for a long time and have disability intermittently or chronically. All right, so why do I show this slide? It's not necessarily just to titillate people. It's really to remind us that the word obsession is thrown around and used in the lay public in a very different way. And when we're talking about obsessions in OCD, we're not referring to preoccupations with a romantic partner or with an idea or your favorite hobby or something else that produces a thrill or excitement or pleasure. Obsessions in OCD are really quite the opposite of that. And they have a very specific definition, of course, in the DSM. And I'll just review the DSM-5 criteria briefly, because I know most people have covered this before, but I think it's always worthwhile to remind yourself, because as I mentioned, I still see a lot of misdiagnosis, overdiagnosis, underdiagnosis out in the community in the patients that are referred to our center. So obsessions are defined by recurrent and persistent thoughts, urges, or images or fears that are experienced at least at some point during the disturbance as intrusive, unwanted, or excessive. And in most individuals, they cause marked anxiety or distress. Sometimes the distress is a little bit nebulous, or it can include other features such as disgust or shame. But anxiety is probably the most common emotional response to obsessional fears. And the individual attempts to ignore them, suppress them with some other thought or urge or impulse, or to neutralize them with a compulsion, some other behavioral action or mental compulsion. Compulsions also have a very specific definition. And again, we are not referring to repetitive behaviors that are done because they're intrinsically rewarding, like gambling or fire starting or sex or substance use. Rather, the behaviors that are defined as compulsions are defined that way because they have a specific function. So they include repetitive behaviors such as hand washing or cleaning, ordering and arranging, checking, or even covert compulsions such as mental compulsions, praying, counting, repeating words in one's mind, self-reassurance, mentally reviewing prior events that the person feels driven to perform in response to an obsessional concern or according to rules that have to be applied rigidly. So again, these compulsions are not rewarding. They serve the purpose of diminishing anxiety. So they're aimed at preventing or reducing anxiety or distress or preventing some dreaded event or situation from occurring. But you make a call as a clinician that these behaviors and mental acts are either excessive or are not connected in a realistic way with what they're designed to neutralize or prevent. For example, washing one's hands is an adaptive and healthy thing to do, after we use the restroom, before preparing food, if we're out working in the yard or something, or with toxic chemicals, or physicians between patients, right, between exams. But washing your hands 300 times a day, if you're staying home all day, is clearly excessive, right? And washing and cleaning compulsions, checking compulsions can sometimes expand to take up many, many hours of the day and become crippling, right? Young children may sometimes not be able to articulate exactly why they're doing particular behaviors or mental acts. So we have to see that the compulsions and obsessions fit in a particular way, and we'll go through that. So the symptoms in OCD have to be time-consuming, taking up more than an hour a day, for example, or they have to cause clinically significant distress or impairment in social, occupational, or some other important area of functioning. And you have to make sure, of course, that they're not directly due to or caused by the physiological effects of, let's say, a substance, a drug of abuse, such as sometimes stimulants, or withdrawal states, or other medical conditions. And most of these are neurological disorders or neuroendocrine conditions that can strike at different times in one's life, and some autoimmune conditions that can cause what we call secondary OCD symptoms. And we have to differentiate OCD from its near neighbors in other psychiatric disorders that can sometimes get confused for it. And this is especially true when patients use the word in a variety of different ways. So we have to make sure that the symptoms that we're seeing are not simply excessive worries about real life issues, as we might see in GAD, general anxiety disorder. And we can differentiate them from preoccupations specifically about appearance, perceptions that one is ugly or has some deformation in your appearance, such as we might see in BDD, body dysmorphic disorder. Or make sure it's not just difficulty discarding or parting with possessions that are perceived as useful in some ways, as we might see in hoarding disorder. And we're not including repetitive behaviors that are body focused that are not driven by obsessional concerns, such as hair pulling and trichotillomania, or skin picking and excoriation disorder, or nail biting. And we differentiate from ritualized eating behavior that we might see in eating disorders. Certainly, patients with eating disorders can have a variety of repetitive and compulsive behaviors, but if they're all related to concerns about body image, body size, weight, and food, we classify it as anorexia nervosa, bulimia nervosa, or some other eating disorder. However, many of these patients with these other near neighbor disorders also may have OCD. So we have to see, which of these syndromes are present in a given patient and which ones aren't. We differentiate OCD from preoccupations with rewarding activities such as substance use, gambling, etc., as we might see in addictive disorders, including behavioral addictions such as repetitive internet use or pornography addictions and so on. Sexual urges and fantasies are also different than what we see in OCD. So we differentiate from paraphilic disorders and from impulse control disorders. and from guilty ruminations that we might see in ruminative depression. So a lot of times I've had patients say that they're having obsessions, and what they're really having are ruminations and guilt about events that occurred in their life that make them feel bad. But those are not the repetitive phenomena that we would classify as obsessional concerns. They're not about the future. And we differentiate from delusions and hallucinations and other intrusions that we might see in psychotic disorders, or repetitive behaviors that are stereotyped but not driven by obsessions, as we might see in autism spectrum disorder. So going through this sort of differential each time you evaluate a patient is critically important. And we can specify the level of insight. So most patients with OCD have good or fair insight, but up to a quarter to a third have some degree of impairment in the insight. So you can classify either with poor insight, the patient thinks that maybe their OCD symptoms, their obsessions and compulsions are necessary, or their obsessional fears probably are true, or maybe they have doubt and aren't sure whether they're true or not. So to play it safe, and because they can't afford emotionally to take that risk, they'll still go ahead and do the compulsion or avoidance. And about 5 to 10% of patients with OCD don't have insight. So they have delusional beliefs. We could call this OCD with psychotic features, or OCD with poor insight, where someone is completely convinced that their OCD beliefs are true. You know, they feel that if they touch the table, they have to go wash their hands, because otherwise there's a high likelihood that they're going to catch some terrible bug from the surface of the table. And you can specify a subtype, which is tic-related OCD. Most of these cases are childhood onset OCD with comorbid tic disorders, either in the person's history or currently. And so we know now that OCD is not a monolith. Rather, it's quite heterogeneous. And people with OCD may have some combination of multiple domains of OCD. And the symptoms of OCD fall into fairly consistent patterns. Specific types of obsessions go along with specific types of compulsions. And so in factor analyses and dimensional studies of OCD, what we see is that the symptoms tend to fall into these 4 major domains, or symptom factors, or symptom dimensions. And in a clinical evaluation, you should screen for all of these. Ask people whether they have symptoms in any one of these categories. And if you get a yes, then you pursue and find out the nature of those symptoms. Most patients with OCD, maybe over 60 to 70%, will have symptoms in multiple different domains. And the rest may have one primary domain. And these may morph and change through the lifespan, but they tend to stay fairly consistent in terms of the presence of the domain. So I've grouped these in terms of frequency. So most common, maybe present in about 60% of all patients with OCD, are aggressive or harm-related or danger-related obsessions. So, you know, fear of getting hit by a car, or fear of harming or failing to prevent harm to loved ones or family members, or fear that you made a mistake somewhere that's going to cause a problem, that lead to pathological doubt and primarily checking and reviewing compulsions. Second most common are the ones that most people know about in the lay public. 50 to 60% of patients with OCD will have some degree of contamination obsessions about disease or germs or dirt or toxins or pesticides and so on, that lead to cleaning and washing compulsions or avoidance of touching or barriers. Third most common, may be present in about a quarter of all patients, up to a third maybe of all patients with OCD, are symmetry and order obsessions. And this category includes arranging and positioning or just right sorts of compulsions, and what we call not just right experiences. So having to do things because it didn't feel right. Maybe having to, flip the light switch 6 times. Why 6? Why not 5? Why not 7? I don't know, just because it didn't feel right. Or maybe having to repeat things until they're just right or just perfect. Even when someone doesn't have a specific fear of some terrible thing that's going to occur if you don't do it, but still you can't get through the day because it didn't feel right. And that symptom domain includes a variety of other sorts of miscellaneous symptoms as well, including mental rituals. And then fourth most common are what we call taboo thoughts. These can include sexual or religious obsessions, sexual orientation-related obsessions, pedophilia-related obsessions, blasphemy-related obsessions, fear of committing sins, and oftentimes those lead to either just avoidance or mental compulsions. And these sorts of taboo thoughts, it could be highly aggressive ones, sexual ones, religious ones, are the ones that the patients usually are much more embarrassed about, so they don't necessarily tell you about these unless you specifically ask and you assess them in your patients. And try to normalize them and let them know that they're a very common part of OCD and they're quite treatable. But these are the ones that make patients feel ashamed or make them think that they're crazy and make them start avoiding things. And here's an example, right, of a contamination concern. So when it comes to money, Bob believes you just don't know where it's been, right? He's using these long tongs because he doesn't want to touch the money with his hands. He's using a barrier to cover his face because he's worried about germs being exhaled by people. Here's another example. In this case, there's a family. The wife is reading this off to the husband. You can see how old this slide is based on what she's talking about, taking Polaroids, right? So she's calling him Captain Anxiety. I took some Polaroids before we left. Exhibit A, the stove with all the burners clearly in the off position. Exhibit B, the back door with its deadbolt latch. Exhibit C, with my curling iron unplugged. So who's doing the compulsion of checking all these things and taking photographs? She is. Who has OCD? He does, right? So compulsions can involve the family. The family members can get roped into doing compulsions, to facilitating compulsions, to facilitating avoidance behaviors, and these are difficult to overcome. In fact, they can interfere with treatment of a given patient if they're receiving what we call family accommodation at home or in their workplace. So you have to address the impact on the family members and sometimes involve family members in the treatment itself. Not only do we have to see the presence of obsessions and compulsions, but what we really want to know is whether they fit what I call the fundamental process of OCD, the vicious cycle of OCD, in which the primary phenomenon are the obsessional concerns about contamination or harm or danger or violence or symmetry, etc., that are producing distress in the first place. The distress is what leads to the urge to do a compulsion. So this could be either doing repetitive behavior or avoidance. Avoidance serves the same purpose as compulsion, so we classify them in the cells. And what is the purpose of avoidance or compulsion? It's to relieve distress, but this is usually temporary. And the more times someone avoids and more the times they do the compulsions, all that happens is the obsessional fear gets intensified and produces more distress and produces even a greater need. So people get locked into these loops and they'll tell you that I'm stuck. The more I do it, it's harder and harder to stop. My fear and doubt grow and grow and grow, and I have to do more and more compulsions or avoid more and more and more. So what we need to see is that this is the fundamental process that's occurring in that particular person. And then we want to break this with our treatments, primarily cognitive behavioral therapy using exposure and response prevention and pharmacotherapy, which I'll talk about in a little bit. We have to differentiate that pattern and those OCD symptoms that I described from something that unfortunately has a similar name, but really is not related, which is OCPD, or Obsessive-Compulsive Personality Disorder. And in this disorder doesn't involve any repetitive behaviors. It doesn't involve any intrusive thoughts or even necessarily fear, distress, or repetitive intrusive beliefs or thoughts. Rather, it's a long-term pervasive personality pattern that consists of being aloof, overly conscientious, indecisive, overly scrupulous regarding moral issues, lacking generosity in time or money, excessively devoted to work to the exclusion of appropriate social outlets, exhibiting a pervasive pattern of perfectionism, rigidity, inflexibility, and patients often don't recognize these traits are maladaptive. The main emotional response may be annoyance or anger when people don't do what the person thinks that they should be doing, or if everybody doesn't do it their way because they feel like it's the right way to do it, right? OCPD is not even the most common personality disorder seen amongst OCD patients. It's present in about 20 to 25% of people with OCD. But other personality disorders such as dependent and avoidant personality disorder are actually more common. Those are present in maybe more than a third of patients with OCD rather. And it's not clear that they are genetically or familiarly related as well. So what's the pattern that we see in patients with OCD? The onset is bimodal. The first peak of onset is childhood onset, occurring usually between 8 to 12 years of age, prepubertal. And about 50% of patients with OCD have their initial onset before age 18. The vast overwhelming majority will have it, before their late 20s or early 30s. There's a second peak that's a little bit broader from age 16 to 26. The childhood onset cohort is more male than female, about 1.4 to 1. The adult onset, or adolescent to young adult onset, is a little bit more female to male. So the overall gender ratio is roughly 1.2 to 1 female to male. Pretty close to 1 to 1. That's quite different than what we see in major depression or most anxiety disorders that are usually roughly 2 to 1 female to male. The only patients that we generally see that have their onset, let's say in their 30s, are pregnancy or postpartum onset related OCD. And this is actually a fairly common phenomenon. So you should screen women, especially in the 3rd trimester of pregnancy and in the perinatal period up to even a couple months out postpartum, because they're highly likely to have OCD symptoms. So about 9% of all pregnant or postpartum women develop new onset OCD symptoms. And this can sometimes resolve, but oftentimes will continue through the lifespan. What's the course? In kids with OCD, about 30 to 50% of childhood onset cases will resolve before adulthood. But in adults, it tends to be chronic and waxing and waning, varying with the level of severity based on life stressors. My usual education for patients is that if they have OCD by age 18, they're probably going to have some degree of it off and on through their life. Some people have a very chronic and unremitting course. With other patients, it waxes and wanes based on usually responsiveness to life stressors. Frequent exacerbation of OCD symptoms in the perinatal period and in premenstrual periods in women. And like most of our other psychiatric disorders, OCD does not travel in a vacuum. The vast majority of patients have comorbidity with other psychiatric disorders. So major depression is the big one, present in about 60% lifetime prevalence. Either about a third of patients with OCD have major depression at the time of presentation. Another third will have it in the future or have had it in the past. So that's really the big one. But even bipolar disorder is much more common as a comorbidity in OCD than it is found in the general population. Maybe up to 5 to 10 times as frequent. Dysthymia, also very common. All the other anxiety disorders are overrepresented. They tend to travel together and have some degree of familial aggregation. Social anxiety disorder is most common, found in maybe 40% of all people with OCD. GAD, pretty common as well. Panic disorder in 15 to 20%. PTSD, 15 to 20%. Specific phobia is very common, up to 40%. So you often will see patients who have multiple different anxiety disorders at different levels of severity at different times in their lives. And then we have other disorders that have a preferential comorbidity with OCD that are not necessarily highly comorbid in patients with other anxiety disorders like panic disorder or social anxiety, or in mood disorder patients. These are more specifically highly comorbid with OCD. And those include the disorders that we call OCD spectrum disorders or OC-related disorders. These include tic disorders, Tourette syndrome, and other either motor or verbal tic disorders that are quite common and have a strong genetic relationship with OCD. It also includes body dysmorphic disorder and some of the somatoform disorders, particularly hypochondriasis, or what it's now called is illness anxiety disorder. And then the body-focused repetitive behaviors that include trichotillomania, excoriation or skin-picking disorder, and onychophagia or nail biting. And then some eating disorders. All of these appear to have high comorbidity with OCD as well as a genetic relationship with OCD. But even disorders that are not genetically related, such as psychotic disorders, are still overrepresented. So about 12 to 15% of patients with OCD have also a comorbid significant psychotic disorder, schizophrenia, schizoaffective disorder, or schizotypal personality. Especially in the childhood onset cohort, a large proportion will have ADHD. So 15 to 20% of all OCD patients in childhood onset OCD, it's probably more like 40% have comorbid ADHD. Substance abuse is not dramatically overrepresented, certainly not as highly comorbid as with depressive disorders or with anxiety disorders, but it's still somewhat higher than what you'd see in the general population. So how do we recognize and screen for OCD? And I would advocate doing this with all initial evaluations in a mental health setting. And certainly in all patients who present with any symptoms of anxiety or depression, simply because the comorbidity is so high and the disorder is often missed when people don't ask specific screening questions. So you look for telltale signs like dermatitis or red hands, or repetitive movements that you might see even in the session, or odd avoidance patterns that you might notice that the patient describes. And you ask basic screening questions. There are 6 questions that if you ask and get a yes answer, have fairly high specificity and sensitivity. So over 80% sensitivity and specificity for the diagnosis of OCD or ruling it out. Do you have to wash your hands over and over again? Do you have to check repeatedly? Do you have repetitive thoughts that distress you that you can't get rid of? Do your daily activities take a long time to finish? Are you concerned with symmetry or orderliness? Do you have any repetitive behaviors that are difficult to control? So this last one screens not only for OCD, but for all the other disorders. It can include impulse control disorders or body-focused repetitive behaviors or anorexia. So it's a broader one, but the first 5 of these are more specific to OCD. And then you can use well-validated self-report quick screening tools like the Obsessive-Compulsive Inventory Revised. That's a fairly quick self-report measure. I think it has like 15 or 16 questions. Patients can fill that out in about 5 to 10 minutes, and it gives you an indication of the presence and severity of symptoms in a variety of different symptom domains of OCD. The Florida OCI is also a quick screener that can be done in maybe 10 minutes. A longer but more thorough and comprehensive checklist of OCD symptoms is found in the Yale-Brown Obsessive-Compulsive Scale, or YBOX symptom checklist. And the YBOX, of course, has a severity scale that's the gold standard for clinician-administered severity ratings. So how do we treat OCD? There are really only 2 types of treatment for OCD that have been found to be effective. And these have been the gold standard treatments for OCD for over 40 years. Pharmacotherapy, primarily with serotonin reuptake inhibitors, along with some adjunctive treatments, and cognitive behavioral therapy, specifically using exposure and response prevention. Cognitive therapies by themselves, so simply doing cognitive restructuring or stress management or mindfulness, or ACT, some of the third wave psychotherapies by themselves, if they're not paired with exposure and response prevention, don't appear to be effective so much on their own. They may be good adjuncts, so adding on mindfulness, or adding on DBT, adding on ACT, adding on cognitive restructuring on top of exposure and response prevention certainly can enhance it, but they are not a substitute for doing the exposure and response prevention. Other types of psychotherapies, psychodynamic therapies, supportive therapies, a variety of other types of therapies are ineffective for the core symptoms of OCD. And in fact, sometimes they can actually make patients worse. They certainly can help patients cope with having the disorder, but they don't necessarily get rid of the symptoms of the disorder. And they certainly can help with all the comorbidities. So they may be very important for comorbid personality disorders, relationship problems, mood disorders, other anxiety disorders. But sometimes we see patients who've been in other types of therapy for 15 years, 20 years, and they feel better in general, and maybe they're functioning a bit better, but their OCD symptoms haven't budged. And that's because they didn't have the right kind of therapy, right? So there is no substitute there for exposure and response prevention. ECT appears to be highly effective for refractory mood disorders, refractory bipolar or psychotic disorders, but it appears to be largely ineffective other than a couple case reports for refractory OCD. Neurosurgical interventions can be very effective, and these are used as a last resort only for highly disabled and very severely ill patients who have failed to respond to aggressive combinations of medications and usually intensive cognitive behavioral therapy, oftentimes in partial hospitalization settings, residential settings. If they still haven't responded, we can refer them for particular types of neurosurgical or neuromodulatory interventions, such as deep brain stimulation, repetitive transcranial magnetic stimulation, or TMS. And sometimes these can be helpful. In general, for most patients, most adults, most kids with OCD, a combination of ERP and medication is more effective than either treatment by itself. And that's a general rule that covers the vast majority of patients. And that's really the education that you have to provide for yourselves as clinicians, but also to families and patients. Let's talk first about pharmacotherapy, and I'll review this quickly. All the first-line agents that have either received FDA approval in the United States or abroad are strong serotonin reuptake inhibitors. They're not necessarily specific or selective, but they're all strong serotonin reuptake inhibitors. These include the relatively more selective ones, such as citalopram or Celexa, escitalopram or Lexapro, fluoxetine or Prozac, fluvoxamine or Luvox, paroxetine or Paxil, sertraline or Zoloft, or the tricyclic antidepressant clomipramine or anafranil. It's the only one of the tricyclics that is extremely strong as a serotonin reuptake inhibitor as compared to its other properties, its norepinephrine reuptake inhibitor properties. It's important to remind you that these other medications are really not necessarily all that selective. Sertraline is a stronger dopamine reuptake inhibitor than Wellbutrin, for example. Paroxetine has fairly significant anticholinergic and norepinephrine reuptake inhibitor effects. So calling these very selective is actually somewhat of a misnomer. But definitely these are more selective than clomipramine is. These are all roughly effective at the same level. So head-to-head trials don't reveal any significant differences between them. Large population studies and meta-analyses show that they're all roughly about the same. However, a given patient may respond significantly better to one than one of the others. So it's worthwhile to switch between them if either a patient doesn't tolerate the side effects to a given one or did get a good response. So just as we do for mood and other anxiety disorders, we may try serial trials of different SRIs or shift to the less selective ones like clomipramine if we're not getting a good response to the first one or the second one. I'll call your attention to the dosing because this is very frequently missed in clinical practice by people. The usual daily doses that are required for OCD symptoms to improve are often double or triple that required for depressive disorders or other anxiety disorders to improve. And very frequently patients will come in saying, oh yeah, I've tried all those. And what you find is they didn't have an adequate dosage for OCD, and they didn't have necessarily an adequate duration for OCD. So for example, the doses that are effective of citalopram or Celexa may be 40 to 60 milligrams a day. For escitalopram, often we go up to 30 or 40 milligrams a day. For fluoxetine, usually you don't get a benefit unless you're at 40, 60, or 80 milligrams a day. For fluvoxamine, it's usually at least 200, if not 300 or more. Paroxetine, 40 to 80. Sertraline, usually above 200 to get a good effect. Clomipramine, usually above 150 to get a good effect. And sometimes we'll go even to maximal doses. If a patient, let's say, is a fast metabolizer and they're getting incremental improvement as you march up on the dose, but they're still tolerating it okay, so you have room to move. And you have to document very carefully that you're moving to these doses that are above the usual FDA limits, but most of the time, the FDA limits are usually for depression or other anxiety disorders, or not for OCD. And so you frequently have to exceed them, and you have to explain to pharmacists and patients and insurance companies that the treatment of OCD requires these high doses sometimes. In addition to high dose, you also need a long duration. So SRI response for OCD symptoms is slower than it is for mood or general anxiety symptoms. It often starts later and builds over the course of 8 to 12 weeks. So you have to do a full trial of 8 to 12 weeks at the maximal dose, or at least at an adequate dose. And that's usually, as I said, maybe double what is required for depression before you can say that it failed, right? Early improvement certainly will predict greater improvement in the long run, but not every patient has early improvement. I've seen patients maybe not have medications kick in until the second month of treatment, right? So you have to educate them that they're going to get side effects first, but the clinical improvement in their OCD symptoms may take a while. They need to have enough time at the full dose, and that may take a while even to get to the full dose, and then you have to leave that in place for them to finally start getting their more significant clinical response in terms of OCD symptoms. Luckily, the depressive symptoms, the other general anxiety symptoms, panic disorder symptoms, social anxiety symptoms usually start improving earlier. So depressive symptoms, usually you'll start getting improvement within the first couple weeks. General anxiety, same thing, usually within the first 2 weeks. And so they have to hang in there, of course, to get their more significant OCD symptoms. And in patients who respond to a given treatment, you want to continue maintenance treatment at the full effective dose for at least 12 months in patients who respond. Why is that? Because if you stop early or taper too early, there's a very, very high rate of relapse. So in general, what outcomes should you expect? Roughly 40 to 60% of patients respond to any given adequate trial of an SRI medication, right? So that's not necessarily that high. Each given trial, you might only get half of the patients responding. So that's another reason why you need to do serial trials. If you do repeated trials of different SRIs in different classes, including the less selective ones like clomipramine, you can get that response rate up to maybe 60 or 70%. However, is it a complete response? Do these medications by themselves cause OCD symptoms to go into remission? Rarely, right? Even those who respond usually only show a mean 40 to 50% reduction in symptoms. And if you look at all patients, let's say in a given clinical trial, the mean reduction of symptoms is only about 30, 35%. Within the responder group, let's say those half of patients in a trial who respond, their average response improvement on, let's say, a scale like the Y-box is only around 40 to 50%. So you have to educate them that, no, the symptoms are not likely to go away. You might get them down from, a 30 to a 15, let's say, if you're lucky, with medication alone, but they're still going to have OCD symptoms that are significant. And then what do you need to do? You need to make sure that they're also getting CBT with ERP. And even in responders, if you discontinue medication and you don't do behavioral therapy, you have a very high relapse rate. So about 2/3 within the first year. If you track patients 2 years out, it's about 80% will have a recurrence or relapse if you don't do a substitute treatment like behavioral therapy. What about if a person can't tolerate any of the SRIs or they don't get a good response to any of those? Can we try some other monotherapies? Very few other things have been studied that are as effective. Venlafaxine is probably effective. I've used it in many different patients, but the clinical trials produced sort of mixed results. There were a couple positive ones, a couple negative ones. So it would be lower on the list than the other SSRIs or clomipramine. There's only been one placebo-controlled trial of mirtazapine. It was positive, but there have been no head-to-heads and no further data. So again, it would be much lower on the list. IV ketamine, there are 2 placebo-controlled trials, both done by a group at Stanford, and they looked positive, but it's a very small sample, and we're quite a long ways from getting an FDA approval for IV ketamine for refractory OCD. So the data is nowhere near as robust and expansive as it is for major depression or bipolar depression. Duloxetine hasn't been studied in a controlled trial, looked okay in an open trial and a small augmentation trial when it was added on, but it's going to be much farther down the list. And unfortunately, the other serotonergic agents like vortioxetine or Vibrid, vilazodone, vortioxetine, Trintellix, vilazodone or Vibrid, or Desvin, Lafaxine, Pristique, no really significant controlled studies or open trials, just a few case reports that looked promising. So while there's a theoretical reason that you would expect that patients' OCD symptoms would respond to these, and I certainly have seen and had patients who were on those medications and they did respond, but we don't know what the response rate is, what the overall proportion of OCD patients who are going to respond, because they simply have not been studied well. Well, what do we do for the 40 to 50% of patients who don't respond well, or all of those who got a partial response? Because partial response to SRIs is the rule, right? Most patients are going to get somewhere in the neighborhood of 30, 40% improvement on their SRI. That's not going to cause their symptoms to be in remission. They may still have functional impairment. So what do we do at that point? We can augment, right? And what I've listed on the next few slides are the different categories of augmentation strategies. And in particular, I've underlined the ones that have been found to be more effective than placebo in randomized controlled trials. So the biggest category includes atypical antipsychotic medications, right? And all of these appear equally effective. In the meta-analyses, aripiprazole and risperidone probably have the highest effect sizes, but there are given patients sometimes who might do better with quetiapine or olanzapine, especially if they are having insomnia and or problems eating or maintaining their weight. Certainly, you wouldn't want to use those medications in patients who have obesity or overweight. All of them, if you look at the clinical trials, will produce improvement in about 30 to 50% of patients who hadn't previously gotten a good response from their SRI. And then the reduction of symptoms is again adding on maybe another 30, 40% reduction in responders. So they're not magic bullets, but they're oftentimes can convert somebody from a non-responder to a responder. The older antipsychotics, neuroleptics, we don't use these very often, but there certainly have been found effective, especially for tic-related OCD or schizoobsessive, those patients who have comorbid psychotic disorders and OCD. But atypicals are also effective for tic-related OCD and schizoobsessive patients. So we're primarily using these. It's rare that we're ever going to go to one of the first generation agents. Clomipramine is not only used as a monotherapy at higher doses, but at lower doses can be used as an adjunctive treatment, and it has been found to be effective as an augmentation to a selective serotonin reuptake inhibitor, usually at doses ranging anywhere from 50 to 125, let's say, milligrams a night, added on to an SRI. Glutamate modulators have been studied recently. There's good controlled data for memantine or Namenda, although clinically I haven't found it to be as effective. There are mixed results for N-acetylcysteine, which is an over-the-counter supplement that is a glutamate modulator. Other ones have been studied, like riluzole, or a newer one that's undergoing clinical trials right now is trigriluzole from Biohaven, a company centered right there in Connecticut. Other ones have been studied, like ketamine as an augmentation, was not found better than placebo. So the jury's still out on these. However, another classification of medications, serotonin 3 receptor antagonists, so ondansetron, granisetron, there are a couple other ones. These are used primarily as treatments for nausea or for other gastrointestinal disorders. But in fact, they've been found to be effective as adjunctive treatments added on to SRIs for OCD. And even when used by themselves, they can have a mild anti-general anxiety effect with patients. But for OCD, they don't seem to work by themselves, but as adjuncts. And especially for patients who also have, let's say, irritable bowel syndrome, or also have chronic nausea along with their OCD or other anxiety disorders, these are great medications to add on because sometimes you can get multiple effects. There are several controlled trials showing that certain anticonvulsants can also be effective as adjuncts for refractory OCD. So lamotrigine and topiramate have several placebo-controlled trials showing efficacy. Pregabalin, gabapentin, carbamazepine had either mixed results or failed, so I usually don't go to those. But there are certain subgroups of patients who have a good response to lamotrigine or topiramate added on to their SRI. Pindolol is another one that's had mixed results. Some patients responded, some patients didn't. So I put it on the list, but it's going to be well lower down. Interestingly, there are controlled trials of adjunctive morphine as having a specific anti-obsessional effect that did not correlate specifically with the sedative effect or the analgesic effect or the euphoriant effect. The effects usually kicked in over the course of a couple days and lasted for about a week, very different than the analgesic effect. So the pathways in the brain that involve, that mediate OCD include opiate receptors. And so it would make sense that various types of opiate receptor modulators like morphine would have an effect. There are even older studies done in the 80s for stimulants. There are studies of dextroamphetamine, there are studies of caffeine that found some significant anti-OCD effect. And then European studies of agamelotine have been found effective. So there's one controlled trial and one open trial that are positive. Mirtazapine has had mixed results. It was better than placebo in one of the control trials. Another one, it wasn't better than placebo, but it did seem to accelerate response. So it would be on the list as something, a combination to consider. Benzodiazepines have not been found to have a specific anti-obsessional effect. We do sometimes add them on, let's say for patients who have coexisting panic disorder, coexisting residual anxiety, or chronic insomnia, but you have to use them, of course, very carefully and screen patients very carefully for histories of current substance use and monitor very carefully for either the development of tolerance or dependence, or for cognitive effects and so on, or sedative or depressant effects. Well, what about the other major therapy for OCD? It's behavioral therapy, and specifically ERP, exposure and response prevention. And let's move through this pretty quickly because I want to get to hoarding disorder before we run out of time. Oops. So behavioral therapy for OCD has to include both exposure and response prevention. Both components are required. In vivo or imaginal exposure using multiple modalities has to be prolonged or repeated. And then it has to be paired with response prevention or ritual prevention. And that has to include not only physical rituals, but mental rituals and avoidance. Mechanisms for action of ERP include fear extinction, and inhibitory safety learning. Highly effective. In fact, the effect size for ERP is higher than that for medications. Choice of initial treatment in the practice guidelines would be CBT alone for kids or adults who have mild to moderate OCD without significant comorbid depression or other disorders. Also for patients who refuse medication or avoiding medication, or for pregnant or breastfeeding women. SRI alone might be effective for patients with poor insight who aren't willing or able to participate in CBT, who don't have the motivation, or maybe they have cognitive impairment that impairs their ability to follow the instructions of CBT or comply. But really for everyone else, for the vast majority of patients, especially those who have comorbid other psychiatric disorders, you're going to need a combination. And even for moderate levels of OCD, you rarely get to remission unless you combine SRIs and CBT. All right, let me move forward here so we have a little bit of time to talk about hoarding. So here's hoarding in a nutshell. I know it's good for nothing, but I'm keeping it until it's good for something. So hoarding is defined as the acquisition of an inability to discard worthless items, even though they appear, at least to other people, to have no value. This was the initial clinical definition from Randy Frost and colleagues in the early 90s. That was then expanded by our work group in the DSM-5 to create the initial diagnostic criteria, which finally made it into DSM-5. Persistent difficulty discarding or parting with possessions regardless of their actual value. So it might be stuff that was very expensive to buy, or it might also include just most items that most people would have tossed because they weren't worth anything. The difficulty has to be due to a perceived need to save the items and emotional distress associated with discarding. So not just because somebody has cognitive impairment or physical disability and isn't able to throw things away, or has severe depression and they don't have the motivation to throw things away or clean up their home. The symptoms have to be severe enough to result in the accumulation of possessions that congest and clutter active living areas, work areas, outside areas, car, etc. And if those areas are uncluttered at the time of evaluation, you have to make a determination that that was only because of third-party intervention. So if the family members or authorities come in and clean out the house, that doesn't mean that the person doesn't have hoarding disorder, right? They didn't magically get better just because somebody cleaned their home. The key is, were they able to do it themselves, right? Because cleaning out the house is cleaning up the consequence of hoarding disorder. It's not actually affecting the person. You're treating the house, you're not treating the person there. And you have to make a determination that the hoarding is causing clinically significant distress or impairment in social, occupational, or other important areas. And that includes maintaining a safe environment for the self and others in the home. It includes maintaining a safe environment for pets, for other family members living there, etc. And you have to make sure that the hoarding and saving symptoms are not attributable to some other medical condition. There are certainly particular neurodevelopmental or neurodegenerative conditions that can present with hoarding symptoms. And you have to make sure that what you think looks like hoarding is not simply due to another disorder. So let's say that people with contamination fears might be afraid to throw things out because those things feel contaminated and they want to protect the garbage people or people walking near landfills from getting contaminated. So they store all that stuff in some container, right? You have to make sure that it's not simply due to decreased energy or motivation, or that people aren't keeping things because of delusions and hallucinations in a psychotic disorder, or because of cognitive deficits, or because of the restricted interests and collecting behavior that you might see in autism spectrum disorder. And you can specify with or without excessive acquisition. But about 80% of patients with hoarding disorder have either had or do have excessive acquisition. And that can include saving or collecting or acquiring free items that are given away, or even dumpster diving, or excessive buying, or even stealing. Right? So compulsive shopping and buying certainly can be a part of hoarding disorder, and even kleptomania sometimes, although that's relatively rare. The key is someone getting more items than they have space for and more larger number of items than they really need, right? And you can then also categorize the level of insight. And here it differs from OCD in that there are a lot more people with hoarding disorder who have poor insight. So estimates suggest that maybe half of patients with OCD, with hoarding disorder rather, either have poor or absent insight, where they're completely convinced that they really need to hang on to the stuff, that it's critically important and they don't want anybody to touch it because they really need it, right? Even though most people would think that those things are totally useless. So there's a lot of talk about and media stories about animal hoarding, hoarding of multiple cats in the home, often in terrible condition, hoarding of dogs in the home. This appears to be a separate phenomenon. It's driven by different things, and so there's very little overlap between hoarding of objects and possessions versus animal hoarding. There are certainly some patients who have both, but it's rare, and the pathophysiology and the psychopathology is quite different. However, there seems to be hoarding by cats, right? So this is Hoarder's House Cat edition on A&E, and here's this cat saying, "I don't have a problem, I'm just disorganized. Don't throw my twisty tie away." And this gets at the point that there are, in fact, animal models for hoarding. There are dogs, cats, species of bluebirds who hoard either toys or non-food items in their nests, let's say. And these are animal models for the hoarding behavior. It's even more common than OCD, right? So maybe 2 to 3 to 5% of the population meets full clinical diagnostic criteria for hoarding. And that's an estimated 6 to 10 million people in the United States. So it's not merely a subtype of OCD, it's actually even more prevalent than OCD. And it also starts early in life. So the onset of initial symptoms, and that's usually indecisiveness and difficulty discarding something and distress with discarding, start at around 12 to 13 years of age. And it sometimes can present in childhood, even earlier than that, but certainly in adolescence. And then it tends to get worse over time as people start to be able to acquire more. And there isn't someone in the home, like a parent or a roommate, to clean the stuff out. So when people are living on their own, or now they have an income, they might acquire, they have their own space, clutter tends to accumulate. And so if you track people through the decades, symptoms can go from mild to moderate to severe as they get into their 30s and 40s and 50s. And unfortunately, patients often don't recognize this until they're, so when you ask people, well, when did it start? They usually tell you when the clutter got bad enough for them to notice. And so they'll say, oh yeah, it started, when I was 45 or 50, when we were living in such and such house. If you ask them, wait a minute, when did you first have difficulty discarding things that other people might have to, push you to discard, or they discarded for you? That usually goes back to childhood, right? What do people with hoarding disorder hoard? Well, it turns out they save the same things that most people save. Could be reading material, newspapers, books, could be clothing, but even old clothing that doesn't fit anymore. Could be old bills and receipts and statements that, might be 30 years old, but they feel like, well, maybe I might need it, so I got to keep it, right? Storage containers, mail, junk mail piles up because, well, what if I might need it? I might use that coupon, but I don't have time to go through it, so it piles up, right? Notes and lists. Memorabilia, a lot of material that's saved is for emotional reasons, sentimental reasons, like someone saving every report card that their child ever had, even though the child is now 35 years old, or every toy that their son or daughter had, or every old item from a deceased relative. They'll keep it in their house because it reminds them of the relative. And then there's some idiosyncratic items, broken things that the person thinks can be fixed, where there's no reasonable reason why they could fix that, etc. Here's an example of one of the patients who was in the UCLA partial hospitalization program back when I was there, had piles up to 4 feet high, congesting their living room, so there was no way you could even walk through there. There's another patient who actually thought that they were very well organized because they had the stuff organized into these different bags and they knew what it was, but it still congested their living space. They weren't even able to get to the fireplace or to the exit in the back room there. What are the reasons people with hoarding disorder hoard? Turns out the reasons are also the same as most of us will save things. We save things for utilitarian reasons, a perceived need to save the items. Might be able to use it someday. I could fix it. I could sell it on eBay. I shouldn't just throw it away. Might need it, or I paid good money for that. It was valuable and expensive. So even though, let's say somebody has 400 pairs of socks, well, they paid for those socks. They don't want to get rid of them. I want to make sure that I could sell them or something. So perceived need or emotional attachment to the possessions, sentimental attachments, memorabilia, reminders of loved ones. And sometimes the reasoning has to do with wanting to avoid wasting things, wanting to make sure that the possession goes to a good home or is used in some way rather than discarded. So these are the same reasons for hoarding patients as for healthy controls, but the difference is in extent and amount. So we may look at our homes and say, okay, well, there's only certain things that I really, really need to keep. There's a lot of things that, yeah, I could probably discard. I might want to keep them, but I don't really need to keep them. But that feeling of need gets attached to a much greater number of possessions, maybe all of the possessions that a person has with hoarding disorder. And there's much greater emotional attachment to possessions than in most people. So the same sorts of psychological processes, only expanded and exaggerated to a pathological degree. And the cognitive behavioral model for hoarding includes information processing deficits. So people with hoarding disorder show on neurocognitive tests, difficulties with organizations, difficulty categorizing. They have a difficulty putting things into general categories, and they usually over-categorize, so that everything has its own category, and that's why they have difficulty putting things together. They have a lot of doubts about their memory. They have difficulty focusing attention, not so much on incoming stimuli like reading or watching something, but focusing attention on tasks. They tend to be highly distracted from tasks, so they bounce around from one thing to another. By the end of the day, they've started 16 things and haven't finished anything. And they have significant problems with decision-making, strong indecisiveness and distress and anxiety related to fear of making the wrong decision. They also have excessive emotional attachment to possessions. They may have distorted beliefs about the importance of possession, a feeling of responsibility for every possession, and poor insight or at least overvalued ideation. These are all significant factors, and these are factors that are different than what you see in patients with OCD. And so our colleagues and I described what's called the behavioral syndrome of compulsive hoarding that includes not only the core symptoms, obsessional concerns and perceived need to save, clutter, that's a consequence of the hoarding and saving behavior, excessive acquisition, but also these other, what I call associated features: indecisiveness, procrastination, avoidance, perfectionism, difficulty organizing in a broader way, difficulty organizing time, so having trouble maintaining even a basic schedule of sleep and wake, eating, activities, disorganization of your activities, disorganization of your possessions, even disorganization of language. So many people with hoarding disorder have significant thought disorganization. They have circumstantial, over-inclusive language. And they're often slow and late to appointments, and they churn. They may think that they're going through things and sorting their stuff, but they have difficulty actually discarding it and having it leave their home. So there's neurocognitive deficits that present in daily living, trouble with decision-making, categorization, as I mentioned, organization, problem-solving problems, a lot of what we call executive functioning difficulties. So there's some phenomenology that's similar to OCD in that, yes, there are some core obsessional fears and there are some compulsive behaviors, but there are also urges that are egosyntonic and rewarding intrinsically. And that's where we have a difference from OCD. And there's a great deal of avoidance. Hoarding symptoms don't actually correlate that strongly with typical OCD symptoms like contamination or harm or danger obsessions or symmetry. Only about 16 to 25% of hoarding disorder patients also have DSM-4 criteria for OCD. And that's another reason why we know that these are separate disorders. And importantly, hoarding disorder has distinct brain abnormalities that are really different from those in OCD. In terms of comorbidity, OCD is not even the most common comorbidity. Actually, major depression is, and then ADHD has a strong comorbidity. Over a quarter of people with hoarding disorder also have ADHD. And they also have a lot of medical comorbidity. So even after correcting for age, gender, BMI, race, psychiatric medications, tobacco use, education, those with hoarding disorder has significantly higher lifetime rates than controls of diabetes, chronic pain, any metabolic syndrome, cardiovascular disease, elevated lipids, and sleep apnea. And these can have their own consequences and also exacerbate the hoarding and vice versa. Even people with subclinical levels of hoarding disorder have significantly higher lifetime rates of those disorders, but not as high as those with full HD. So it's not just a consequence of having full-blown hoarding, it's seemingly a part of the syndrome. There are positive correlations between hoarding symptoms and cardiovascular and metabolic morbidity. So not all clutter is due to hoarding. It may be due to a variety of other things, physical problems, ADHD, depression, etc. Compulsive hoarding is a neuropsychiatric disorder that has in its basis neurocognitive difficulties and abnormal patterns of brain functioning. It's not merely laziness, obstinance, or problems just with organization. It can cause severe functional impairment and disability. So all of the people presenting with clinically significant behavior, and it's an important thing to screen for because it's even more common than OCD and it's sometimes more disabling than OCD. So you can use self-report measures like the Saving Inventory Revised. You can use a clinician-administered scale like the UCLA Hoarding Severity Scale. And then there are some hoarding questions on the OCIR that I told you about. When you evaluate a patient, you also have to ask them about health and safety hazards in the home, right? Because these are going to be important, immediate things to take care of. If there's a fire hazard, a health hazard, dust, mold, infestations, rats, cockroaches, and things, blocked fire exits, right? These are things that have to be mitigated and dealt with immediately. And their level of functioning, their level of insight and motivation for treatment, sometimes that's really low, comorbid disorders, other family history, social environmental factors that are maintaining or worsening it. So these are some important assessment questions. How much clutter do you have? What is the main stuff that clutters up your home? What does it consist of? Where is it? What do you have health or safety hazards? Do you have strong urges to save things? And if so, what do you have strong urges to save that most people would have thrown out? You have to assess their beliefs and fears about, what would happen if they didn't have that material? Why is it that they have an urge to save? What would they think might happen? And you have to assess for associated features, because some studies have found that the associated features are sometimes more functionally impairing than the hoarding and clutter itself. So procrastination, avoidance, indecisiveness, not only about what to throw away and what to keep, but about any decision in their life sometimes, and the broader disorganization of time, language, thought, activities. What's their level of support? Is very, very, very difficult for people with hoarding disorder to do it on their own. They almost always will need help from family members, co-therapists, therapists who work in the home, professional organizers who assist, clutter buddies who come and help them. Having another person work with you is a predictor of response, and not having someone work with you is a predictor of poor response to treatment for hoarding disorder. What works? It's some of the same stuff that worked with OCD, some medications, certain types of cognitive behavioral therapy that have been specifically tailored for hoarding disorder, and specific types of peer support groups that use a manual called the Buried in Treasures workbook. Buried in Treasures is a book written by David Tolan, who's in the Institute of Living in Hartford, Connecticut. Other psychotherapies, again, ineffective. 12-step approaches like Clutters Anonymous, Hoarders Anonymous don't work. House cleaning by others, ineffective. Right? I won't go through these because I know we need to get to Q&A. So just in terms of the conclusions about medication treatment, the conventional wisdom that used to be present that hoarding disorder didn't respond well to medication treatment is wrong. There were 2 major open trials that our group did, a few studies from groups in Europe that found that medications like venlafaxine XR and atomoxetine could be significantly effective for hoarding disorder, even outside of their improvements of comorbid OCD, depression, anxiety. About 3/4 of patients in the open trials of venlafaxine XR and in the European trial of atomoxetine had a good response. And the atomoxetine trial excluded people with ADHD. Right, so atomoxetine or Strattera is a medication FDA approved for ADHD, but these were all patients who didn't have ADHD. Pharmacotherapy appears to be at least as effective as CBT, roughly 30 to 40% improvement in symptoms compared to about 20-30% for CBT. It's superior for the comorbid mood and anxiety disorders, and it works a lot faster in 12 weeks. So let's open it up for questions. I'm sorry I didn't get through everything, but there's more material and maybe we can address it in the Q&A.
Dr. Saxena, that was such a privilege to get to hear you present all that information. Thank you so much for this. I'll get straight to the questions. So they keep rolling in. I see lots of thank yous and 22 questions that we won't be able to get to, but I can get to a couple. So thank you. Our group, some questions are around COVID, and did we see an increase in OCD related to the whole like psychological experience of COVID and hand washing and those encouragement, as well as can COVID itself, like Panda's relationship to strep, can COVID, the virus, induce an OCD like syndrome? So there's two different questions related to COVID.
Yeah, well, the short answer is yes to all of the above, and let me go into detail on each of those. There were good studies in the US as well as in England and China about the impact of COVID on OCD symptoms. And what was found is that for patients who had OCD already, a large number of them had exacerbation of symptoms, as you can imagine, particularly the contamination-related symptoms and cleaning, washing behavior. And that was specific to people who weren't already in behavioral therapy. Those who actually handled it without a major exacerbation of symptoms were ones who were in behavioral therapy at the time. So they had coping strategies and they were working on, and they were actively involved in fighting their compulsions and resisting the obsessional thoughts when COVID hit. So they had a structure in place to help. It was the patients who weren't in active behavioral therapy that tended to have the exacerbations. There were also de novo contamination concerns that arose out of COVID, just like what happened, 30, 40 years before with AIDS, or has happened with hepatitis or other infectious diseases that have come along at different times. Any new thing that comes up that's a major stressor in the environment can get woven into OCD symptoms. So we saw patients with OCD who didn't have any contamination concerns at all. Maybe they just had, checking compulsions or symmetry. Now they develop COVID-related contamination or even broader contamination concerns. I had some patients who did not leave their homes at all for over a year. They had everything delivered. They were afraid to even walk out the door and be around they didn't have anybody over to their home. They were complete recluses and shut-ins because of this for very long periods of time, highly disabled. So it had a big impact on OCD symptoms, especially in those who weren't in treatment. Now, in terms of COVID causing or exacerbating OCD symptoms from an autoimmune standpoint, it does look like lots of different viral infections can do that. So there's a phenomenon that PANDAS has now broadened into PANS, pediatric autoimmune neuropsychiatric symptoms, and it's not always pediatric. So sometimes we see people with OCD having their symptoms get worse even when they get the flu or RSV or other viral infections. And it's been described with Bornavirus, with influenza, and certainly with strep, that if there can be exacerbations within the first 4 to 6 weeks during and after a viral infection, and those are usually self-limited and symptoms improve again later. And that happens sometimes with COVID, inactive COVID infections. Neuropsychiatric symptoms in general get worse. Sometimes there was a lag period, maybe several weeks before they got better. The mechanisms were not well studied that I'm aware of. So I don't know that there's much research in terms of the mechanism of COVID-related OCD symptoms, whether it was purely psychological and stress-related or whether there was an autoimmune basis. Don't know.
Great. Thank you. Thank you. So interesting. I could ask you so many questions about this. So some questions about hoarding. First, about the subjective experience for someone with hoarding. There's a question here. Why don't they seem to notice or to care so much themselves? And a second question from somebody is, what do you do if you know someone and you're trying to help a friend with this? What's the best approach?
Sure. Yeah, those are very, very critically important questions. Those are the questions that family members and spouses ask me all the time when they're calling about their loved one who has hoarding problems. Poor insight, as we talked about, is a common feature. The people who presented into our research studies or into clinical trials were a selected group. Those are the people who had the good insight, right? People with poor insight don't come into your research study. They don't even necessarily want to come into treatment. They're often forced into treatment, either because they got an eviction notice or 6 months to clear out, a notice given by the fire department, or because of family members forcing them. So the poor insight has to do, I think, with a number of different issues. It has to do probably with some of the neurocognitive deficits, so the executive functioning. It also has to do with the strength of the distress and the strength of the perceived need to save, right? So if you really feel strongly that something terrible is going to happen if you don't have the stuff and you would be bereft without it, and you've lived that way now, and it's been reinforced by your acquisition and by your clutter and by your saving that's decreased your anxiety over decades, you lose sight of that. Even in other people without hoarding disorder, people sometimes get blind to their environment, right? So, my teenage son had roommates at college who didn't bathe well and didn't have good hygiene. And the room smelled bad when you went in. And after a few months, they were all nose blind to it. They didn't notice it anymore. But if we came to visit, we noticed it, right? So we can, that's just a sense where we can get used to even disgusting smells after a while. We can get used to clutter. Sometimes people won't even see it. It's so normalized for them. And there's also cognitive avoidance. So they don't want to look at the clutter because it feels overwhelming. It fills them with distress. At some level, they know they have to get rid of it or do something about that. And that's too difficult to deal with. So they don't even think about it and they don't want to talk about it. And there's also shame. People are ashamed of their clutter. They don't want people to see it. They might even block up the windows so that nobody can look in. They don't want to have people come to their home because they're afraid they're going to get reported. So there are a whole bunch of different factors that prevent people from accessing treatment, prevent people from fully acknowledging the severity of it, and having good insight and having the motivation. So what do you do about that? You do a lot of motivational interviewing and motivational enhancement. And you try to find an alliance with someone rather than banging heads. We see a lot of arguments between family members saying, oh, you got to clean out. No, I don't want to clean out, right? You have to have treatment for this. No, I don't need it. Leave me alone. What I often advise loved ones is to, rather than directly confronting things that the person clearly doesn't want to confront or doesn't have good insight into, ask about their functioning. Let's say instead of saying, don't we need to clean this stuff out, say, wouldn't you like to have people over at your home? So you want to appeal to some distress that the person can acknowledge. If you're feeling depressed or anxious, let's get you treatment for your depression or anxiety. If you want to have a better social life or have, be able to maintain a job and not have clutter in your workplace that got you fired. If you want to maintain relationships, because let's say somebody left you because they couldn't deal with the clutter in your home. If you want to be able to have people over, those are functional goals. Those are incentives and motivations that then may get someone to say, okay, well, I guess I need to clear stuff out. Sometimes it's very basic things such as you're going to be evicted unless you clear out to some level. So you just kind of have to, otherwise there's going to be a severe consequence financially, losing your home, whatever. So any way that you can hook someone in to acknowledge that there's some level of distress or some problem with their functioning that they're willing to work on, want to work on, and then you go in through that door.
Fantastic. In a minute, because that's what we have left, can you comment a little more about the relationship between hoarding and attention deficit disorder and kind of the co-management of those two?
Yeah, as I mentioned, it's a pretty common comorbidity. About a quarter of people with hoarding disorder meet criteria for ADHD. Even more than that come in and tell you they have ADHD. And the majority of my patients say, oh yeah, I think I have ADHD. And what they're really talking about is the distractibility and inability to stay on task, right? Mm-hmm. If you say, yeah, but can you sit down and read? When you were going through your education, could you study for tests? Could you read, for 2 hours straight? And they said, yeah, no, I can read, I can handle that. But when they look at what they have to do or they start doing something, they get distracted by anything they see. So I think it's a specific intentional impairment, mostly on attention to what someone is doing rather than on what they're listening to or watching. If they say, yes, I can't sit through a movie because I got to squirm and get going or I'm on my phone and I can't read for more than 5 minutes straight before I have to walk around. Okay, that's comorbid ADHD. And so you have to treat the comorbid ADHD just as you have to do with the other disorders, because usually comorbid mood and anxiety and obsessional related disorders will get better to some extent, at least when you treat the ADHD. At least that may make the person able to concentrate on behavioral therapy. It might help them remember to take their medications. It might provide the energy and the motivation to be able to overcome some of the procrastination and actually clean some stuff out or work on their behavioral therapy for OCD. So there's a variety of different ways in which ADHD treatment can facilitate treatment of the comorbid hoarding. And sometimes it's a prerequisite because otherwise the person won't even be able to
Mhm.
make it to sessions.
Fantastic. You're a rock star with a wealth of information and so great at presenting it. So Dr. Saxena, thank you so much for being with us. Thank you everybody out there for staying on, for participating in our program, and hope to see you next week again. Please fill out the evaluation to receive CEU and CME credit. As I always say, we've been connected, and it's been so good to see you. And now comes the disconnection part where we're thrown into the rest of our day. So thanks again. It's great to see you.
Thanks so much for having me. It was great to catch up with you as well. I'm sorry I wasn't able to get to all the material, but people can read it.
Absolutely. Thank you. Thank you so much.
Take care. Bye-bye.
Bye-bye.